breastfeeding is finished. So what about euthyroid pregnancies اللي فيهم ال TPO antibodies positive? Would treatment with thyroxine help? هلا احنا لما طلعنا عليهم there was an association between TPO antibodies being positive and miscarriage rate وهي several studies and it's proven. ومن زمان كنا نشوف بعض الدراسات اللي قالت okay maybe if we treat those TPO positive women with thyroxine the miscarriage rate ممكن يقل. بس lately كان في كذا دراسة in UK وفي اسكندنافيا في هولندا كلياتهم طلعوا على هاي and treatment did not actually help. ما راح أدخل في كل الدراسات بس حطيتها هون in case somebody wants to look at them. But if the TPO is positive, TSH is less than 2.5, there is no need to treat. وحتى ممكن يكون risk if you treat them and they don't need the treatment. So one thing, TPO positive women actually do have a tendency to become subclinically hypothyroid or hypothyroid during pregnancy. So you do monitor their TSH levels maybe every 4 to 6 weeks, sometimes per trimester, and treat them if they become hypothyroid. فهذا الريكاب بس للhypothyroid in pregnancy. إنه pregnancy specific references are less strict than they used to be. كنا نحكي ل 2.5 هلا بنحكي لحد 4 is okay. فإذا بتيجي ست عندها TSH 2.7 2.8 بتكون نحكي لا we don't need to treat everyone. Overt hypothyroidism does definitely need to be treated to prevent the complications. Subclinical hypothyroid you look at the antibodies or depends on the levels ساعتها الواحد بيقرر إذا يعالج أو لا. No role for treating women with TSH less than 2.5 regardless of the antibody positivity. So what about hyperthyroid in pregnancy? هلا الأشياء اللي احنا بنحكيها دائما إنه TSH زي ما قلنا بينزل early in pregnancy because of HCG effect. The most common cause for a TSH to be low early in pregnancy is gestational thyrotoxicosis or just the normal physiology of TSH going down early in pregnancy. حتى لو كان T4 slightly above normal, we don't need to treat because this is self-limiting وعادة in the second trimester or the end of the second trimester TSH بيرجع للطبيعي. طبعا suppression is more pronounced in multiple pregnancies, إذا في hyperemesis, molar pregnancies برضه بيكون TSH كتير واطي لأنه HCG كتير عالي. Subclinical hyperthyroidism is no concern مش زي subclinical hypothyroidism. يعني إذا ست عندها TSH واطي و T4 T3 normal, absolutely no need for treatment. فإحنا دائما in pregnancy we don't aim at the normal TSH even if we're treating, we just look at the T4 and the T3 to correct them. The most common cause for like pathological cause of hyperthyroidism in pregnancy is Graves' disease. الأشياء الثانية كثير أقل يعني toxic nodule ولا multinodular goiter و thyroiditis are less common in pregnancy. Graves' disease معظم الوقت بنكون شخصنا ستات قبل ما يدخلوا pregnancy بس في كم واحدة بتشخصوا during those first few weeks of pregnancy. So it's really important إنه نعرف is this Graves' disease ولا هذا gestational thyrotoxicosis. طبعا ما بنقدر نعمل thyroid scan uptake in pregnancy لأنه already material is contraindicated in pregnancy. So الأشياء اللي نطلع عليها we look at the clinical picture يعني does the patient look like they have Graves' disease في orbitopathy ophthalmopathy في bruise over the thyroid large goiter مرات بالultrasound بتبين a very vascular goiter. وإذا ما عندنا من هذول settings we do look at the TSH receptor antibodies and if they're high that goes with Graves' disease. والشيء الثاني ممكن إذا بنطلع على ratio between T3 and T4 عادة with Graves' disease T3 is much higher than T4 فالريشيو بيناتهم ممكن تعطينا clue. وزي ما قلت إذا T4 و T3 just slightly elevated we actually try not to treat that in pregnancy لأنه الأنتي-thyroid medications have side effects اللي بنحاول نتفاداها. حتى Graves' disease احنا بنحكي في كم من autoimmune disease during pregnancy they get better. فحتى الستات اللي ماشيين على anti-thyroid medications before pregnancy and they get pregnant احنا بنقولهم during pregnancy الثايرويد actually رح تهدى بس as soon as they deliver بترجع الثايرويد بتشد عليهم وتصير toxic again. Adverse effects of untreated hyperthyroidism طبعا بنخاف على البيبي low birth weight intrauterine growth restriction prematurity eclampsia of the set, pregnancy loss, and we worry about congestive heart failure or thyroid storm during pregnancy. treatments احنا دائما Graves' disease نحكي للناس there are 3 options for treatment. قبل ما يكون في اي treatment بالزمانات كانت treatment surgery. هلا حاليا نقدر نحكي انه radioactive iodine is one of the options والanti-thyroid medications is another option. بس طبعا anti-thyroid medications are the preferred treatment in pregnancy لأنه we cannot give radioactive iodine otherwise the baby's thyroid will be برضه تنشط. أما surgery sometimes if it's really severe and patients don't tolerate anti-thyroid medications we can do second trimester surgeries. بس برضه عادة we try not to do that. So the only option عادة is anti-thyroid medications. وبالزمانات كنا نقول okay risk of malformations with methimazole, carbimazole, PTU is not that high, you know, we can treat عادي. But in latest years actually there is a risk of congenital malformations with PTU less than methimazole, but both of them do cause congenital malformations. فإذا نعطي نحاول نعطي the lowest dose possible. وحتى إذا نقدر إنه ما نعطي الدواء in the first trimester we don't unless the patient is very very hyperthyroid. هلا إذا وحدة كانت ماشية على PTU أو methimazole قبل pregnancy نقدر نشوف إذا just a minimal dose والTRAB or the TSH receptor antibodies are negative we can actually stop the medicine. But if they're very hyperthyroid with TSH receptor antibody is very high up we have to continue. And still the recommendation is to switch to PTU in the first trimester. مع إنه الاثنين بيعملوا congenital malformations بس PTU is less than carbimazole methimazole. المشكلة بالPTU إنه actually ممكن يعمل liver toxicity leading حتى ب severe cases that need for a liver transplant. فالPTU إحنا بآخر كم سنة we really don't use it except in the setting of pregnancy. The lowest dose of anti-thyroid medication should be used. ودائما T4 we aim at the high normal or even a little bit above normal. لأنه معظم الدراسات بتقول إنه النصيب تاع البيبي بالثايروكسين is lower than the mother. فحتى لو الأم كان فحصها on the high side the baby فحصه a bit lower. فإذا الأم كان فحصها normal probably the baby is hypothyroid. And we definitely do not aim to normalize the TSH with hyperthyroid babies. هدول malformations اللي related to methimazole or PTU طبعا في كثير شغلات حتى including septal defects في الهارت. بس أول وحدة اللي وصفوها بالميثيمازول was الأبليجيا cutis اللي هي زي punched out lesion في السكالب. وهي أول مرة اكتشفوها ب 1972 وقالوا possibly related to carbimazole. أشياء ثانية كمان الأتريجيا، الأنفالوسيلز في several malformations related to methimazole, carbimazole. بالPTU malformations are a bit different. في periauricular sinus، في urinary tract problems, especially in males ممكن hydronephrosis. الأشياء دي طبعا أي حدا ممكن يصير عنده granulocytosis طبعا بPTU or methimazole. والliver toxicity more in PTU than methimazole. So monitoring during pregnancy. يعني إذا عندنا حدا اللي already we started treatment, yes we do have to monitor the thyroid functions, aim at T4 on the high side. The TSH receptor antibody gives us an idea about the baby. يعني احنا بنعرف انه TSH receptor antibodies they do cross the placenta. ممكن يعملوا hyperthyroidism في البيبي حتى لو الام ما عندها. يعني وحده اللي عامله radioactive iodine قبل 20 سنه and she gets pregnant, الانتيبوديز لسه موجودين and the baby can become hyperthyroid just from the presence of the antibodies. فاحنا we do check the antibodies several times during pregnancy and if they're high we do really need to monitor the baby. أشياء اللي بتبين الفحص مثلا إذا البيبي عنده heart rate أكثر من 160 this could possibly be a thyrotoxic baby. هذا ultrasound showing a goiter في البيبي هذا برضه ممكن يعطينا فكرة. بس برضه الجويتر ممكن تكون hypothyroid يعني إذا شفنا goiter والأم فحصها T4 on the low side بيكون maybe this is hypothyroidism rather than hyperthyroidism. وطبعا babies إذا انولدوا عندهم thyrotoxicosis related to the mother's antibodies تاخذ maybe 3 to 6 months وبتتحسن بس the babies do badly initially. So summary of hyperthyroidism in pregnancy, the most common cause is gestational thyrotoxicosis فهي الفسيولوجي اللي نزلت TSH in pregnancy. وبعدها Graves' disease the second one. هلا زي ما قلنا if needed PTU is to be used in the first trimester بس إذا نقدر ما نعالج it's better not to. Or use the lowest dose possible, maintain the T4 on the high side or just above normal. But don't forget to check the baby and check the TSH receptor antibodies in the mother to assess the risk of fetal or neonatal thyrotoxicosis. في شغله كنت بدي احطها بس نسيت احطها. اكيد انتم بتعرفوا عن البايوتين والايفكت تاعه على الثايرويد فانكشنز. هالايام دائما بنحكي لاي حدا اللي بيستعمل بايوتين انه to stop it at least a week before thyroid testing لانه ممكن يعطي indication كانه حدا عنده Graves low TSH high T4 ويكون بس انه الاسي غلط because of biotin. وكان في كم من حاله that they thought were actually Graves disease وطلع بس من البايوتين. فا I think هلا دور الدكتورة نديمة ولا نعمل الاسئله هلا؟